Hi everyone, it's me, Dr. Samina Rahman, Gyno Girl here for another episode. You guys may already know, obviously I've talked about being a South Asian daughter of immigrants, and obviously I'm a gynecologist in downtown Chicago. Even though I treat and see all ethnicities, religions, and races, I do have a lot of South Asian patients that I see in downtown Chicago. And South Asian being from either India, Pakistan, Bhutan, Maldives, Sri Lanka, Bangladesh, Nepal, so basically the Indian subcontinent. And basically there's some conditions that I see more than others. Obviously, I'll talk about some of the sexual pain conditions that I see or pelvic pain conditions. But I wanted to talk about a specific condition called Polycystic Ovarian syndrome. You've asked, I'm replying. Also, there's a lot of information out there, so we want to make sure that we have the right information. And I want to talk about brown girls and PCOS. So let's do it. All right, so brown girls and PCOS. This is, another topic that I think comes up a lot in my practice. Again, I see a lot of South Asian patients. And so, PCOS stands for Polycystic Ovarian syndrome. It's a condition that in the general population, it impacts about 1 in 10. And so 1 in 10 of my patients will have it. But if you're South Asian, it could be a lot more. In India, there's some data showing that 1 in 5 have it, and then there was a study out of the UK that showed 52% of South Asians in the UK have PCOS in terms of their impact. And so it is obviously affecting our population a lot more, and there are a lot of reasons for that, and we'll talk about it. But first, let's kind of get to the bottom of what is PCOS. Okay, so what exactly is PCOS? We're going to talk about that. PCOS is a constellation of symptoms that results from usually a dysregulation in the hormones. There's genetic factors that, lifestyle factors, and other issues that affect someone's ability to get PCOS. We don't have all the data on it right now, but we know certain people are more predisposed to it than others. Based on their family history. And basically, it's a dysregulation of communication of the hormones leading to a constellation of symptoms. Some people have some of the symptoms, some people have all of the symptoms, some people get treated for everything, some people are just looking to get treated for specific things. So it's really patient dependent on how we treat it and what we're treating, as it can present differently in different people. But if I use my little baby's dry erase board, again, I'm not a medical artist, so beware. So what happens is, say this is your brain here, and it sends a signal to, I'm going to attempt to draw your uterus, tubes, and ovaries. So these are your tubes. This is like maybe your uterus and your cervix, okay? And you have your ovaries here. Oh my God, that's some sort of congenital uterus problem. Now, so it's your endometrium. So the brain sends the signal to your ovaries. Usually like a FSH, gets sent to the ovaries. FSH is called follicle stimulating hormone. What we do is we have basically the ovaries it's trying to promote ovulation, obviously. And the way that we promote ovulation is by forming a follicle, and it's usually a dominant follicle, follicular cyst. And so a cyst is a fluid-filled sac. And so what you end up having is a signal that goes to the ovaries saying, make the follicle, let's get ready for ovulation. But there's some sort of issue in the signaling, maybe insulin has some impact on it, which we'll talk about. But basically, it's getting a signal, and it's making too many follicles here. So I'll show you a picture of and that's why it's called a polycystic ovary, because you get all these follicular cysts that form, but no dominant follicle. And so that can result in not ovulating. And when you don't ovulate, and when these signals get dysregulated, you might have a lining of the uterus that grows and grows, but it doesn't shed to form your period, right? So we're already starting to understand that first you have maybe potentially multiple cysts forming, but no dominant follicle or ovulation occurring. Then you have a lining of the uterus that's getting thicker and thicker, but it's not shedding because of the signals back and forth are messed up between FSH, LH, estrogen, progesterone, the works. Then you have androgens. So maybe you don't know that women have about 1/10 the testosterone that men do, and we need it. We need it for our libido and other factors, sexual function. But also, if you have too much testosterone, you can get a myriad of symptoms. And so what happens is maybe if you have too much insulin hanging out around here, which we'll talk about, maybe it's affecting the signal here, causing the ovaries, which make androgens, to make too much androgen. Your adrenal glands also make androgens. So all of a sudden you have a lot of testosterone, and then you're not ovulating, potentially, or you're ovulating late. And then you have these formations of these polycystic ovaries. And so what symptoms result from that? Well, one is a radiologic finding of polycystic appearing ovaries. So this is a classical kind of look of an ovary that's polycystic and maybe isn't having normal ovulation. The second that we usually find is issues with the menstrual cycle. So you might have what we call oligomenorrhea, which is like usually about less than 8 cycles a year, or you're having delayed, more than 40-day cycles or something to that extent. And basically when you get a flow, it's pretty heavy because that lining has been building up, and then all of a sudden it flows, and it's like 10, 15 days of bleeding. So that is sort of classically how we see these ovulation defects leading to irregular bleeding. The third thing we talked about is the testosterone, right? So when you have too much testosterone in your system, you can develop facial hair known as hirsutism, which as South Asians, we're no stranger to facial hair. And unfortunately, we get, a lot of shame associated with it, which I think in general, we have a little bit more than maybe average. And then on top of that, from what someone with PCOS may even have more. So you might have something that looks like, a light mustache, facial hair around here. You can get it on the nipples. You can get it around the back. You can also get acne, some hormonal acne, as well as some people end up with like temporal balding, like male pattern-ish balding. And so those are all symptoms of high testosterone. Because of the ovulation defects, you might have infertility or subfertility where it's not optimal. And then other symptoms that women with PCOS have been associated with are depression and anxiety. Obviously, when your body is like in a dysregulation state, we know that, it can impact your emotions. And so some people also, we've seen more depression and anxiety related to women that have PCOS, especially in South Asians. Additionally, you can also have libido issues, ironically, even though you have more testosterone, because of the way that you're starting to feel. Some women do develop a diminished desire. And then additionally, what you can have is, along with all of this, you can have either difficulty losing weight, especially around your waistline, or you have weight, so you have either weight gain that has contributed to, or augmented this condition, or you have a situation where you can't lose weight, especially around your abdomen. Okay, so those are some of the symptoms that we talked about with PCOS. How do we diagnose it? So, additionally, one of the other things we have to look at for some women that haven't had their menstruation for a long time is the lining of the uterus, because this is a condition that can lead to either hyperplasia, which is a thickened lining of the uterus, or precancerous changes in the lining of the uterus, or even a cancer of the lining of the uterus. So if your cycles have really been bad, where you're not menstruating for 6 or 9 months at a time, or years at a time, then that might be something that you have to have sampled. But in general, the diagnosis of PCOS is based on what we call for most people use the Rotterdam criteria, which means you have to have 2 out of the 3 things I described earlier, meaning either these polycystic appearing ovaries on ultrasound, you can have signs of elevated testosterone, which would be the facial hair, the body hair, or acne, as well as male pattern hair loss. And then the third thing is looking at your irregular cycle. So either anovulatory bleeding or, the bleeding where you're having like the oligomenorrhea that we described. And so a lot of times your provider may end up getting some blood hormones to rule out other causes, such as thyroid conditions, prolactin problems, and also like congenital adrenal problems that could lead to the testosterone issues. So that's sort of like, you have to have 2 out of 3 of those after ruling out other stuff to get the diagnosis of PCOS. And most people can do that in the office. And once you have the diagnosis, you go through, how we're going to treat the patient. And we do it based on, sort of like the predominant symptoms that they had. So before delving into some of the treatments, which I'm going to brush upon because that could be another video in and of itself. But I want to talk about the South Asian factor again, because, there are some studies showing that women and South Asians that have PCOS basically can get the symptoms earlier and more aggressively. And so you might see it in adolescence. And it might not be the typical sort of body type that we see with classic PCOS. When I was a resident, I remember learning about PCOS, and we always would, the thought was always that they were a little bit on the overweight side, and also, would have acne or facial hair, and then sort of be a certain type of patient would be with classic symptoms. But there's also like a more of a lean PCOS in patients that have a significant family history of metabolic dysfunction and heart disease. And so that's a lot of times we see with South Asian population. On a side note, I'm not a cardiologist, but I do like to emphasize this fact that in the South Asian population, out of all the world's heart disease, South Asians have the burden of 60% of the world's heart disease. So let that sink in. That means if you have a friend who's South Asian, or a family member, or you yourself are, you could probably ask someone in the family and they would say, yeah, so-and-so had a heart attack, or yeah, so-and-so had sudden death and we don't know why. And so a lot of that is attributed to the fact that there's more heart disease, metabolic dysfunction among the South Asian population. And there's a lot of studies being going on to find out, why this might be. There's a great study, the Masala study, and they're looking at reasons and what we can do about it. There might be a factor involved with, how South Asians carry fat. And so if you have more fat in the viscera, your internal organs, like around your heart or your liver or your intestines, there's some thought based on that puts us a little bit more at risk. There's even thought, because sometimes South Asians have a lower BMI, they and still have the same heart disease risk, to change what is considered obese and overweight in the South Asian population, to lower it so that it can be more aggressively managed, to prevent sort of these sudden cardiac deaths or heart disease and diabetes. Of course, we all know that, I'm Punjabi, I love my roti, and my paranthas. But that being said, there is, the factor involved with our diet and lifestyle issues. And I read a study actually about the acculturation of South Asians as they immigrated to the U.S. And basically it was, there was some association that was believed that, based on the acculturation stress, meaning adopting the new culture of Western culture into our lifestyle, which includes the diet, the stress, being overworked, and etc., has contributed to this advanced sort of heart disease and metabolic dysfunction, which would then also help us to understand more about the PCOS issue. So I do tell my patients with PCOS, we should look at their cholesterol, we should look at their insulin resistance by screening for diabetes. We should be vigilant with their heart disease. So, because heart disease is still the #1 killer of women. And so we think about South Asian women, we really want to be aggressive, especially the ones that have PCOS, because we want to make sure that they are on a good diet and exercise program that would lower their cholesterol and help them to, keep their heart healthy. And then additionally, again, I'm not a cardiologist, but I do talk to my patients about that, because I think it's important to prevent these things early on. So even my 20-something-year-olds, I'll check their cholesterol or send them to their primary to make sure they get checked. Okay, so we're going to be more vigilant about heart disease, exercise, diet, and so some of that is sort of the treatment for PCOS in general too. But if we're South Asian, we're going to be a little more vigilant. I recommend a lot of times intermittent fasting for my patients. I myself intermittently fast. I get on my Peloton, that kind of thing. Even though, I'm petite, I still worry about the heart disease issue. And, especially when it comes to menstruation and the importance of having regular cycles when you're not on birth control pills, because, with birth control, you can skip cycles because of the hormonal manipulation. But, so, diet and exercise modification are huge when it comes to polycystic ovarian syndrome. Again, with the metabolic dysfunction, I meant to mention also that there is thought to be more insulin resistance in the population, which is why diabetes happens to a lot of the patients. And that insulin resistance means that there's more insulin in your blood. And so that might be what I was talking about earlier, impacting the regulation of your normal ovarian function. Okay, so we talked about diet, exercise, the importance of that, for your heart health, and also maintaining your weight, and also, maybe maintaining menstrual cycles and regulating yourself hormonally a little bit better. Obviously, if we want to make sure that you do get a normal cycle to keep that lining of the uterus healthy, then we do also incorporate birth control pills, oral contraceptives, IUDs, the ring, the patch, other things. So, depending on the patient, we have this discussion, like how are we going to make sure that you get a menstrual cycle until metabolically you feel better. Some people also advocate the use of metformin, and I have this discussion with patients sometimes. Metformin is a drug that's also used for insulin resistant diabetes. And so, but there has been some studies on metformin, and we'll talk about that in the other videos. And then additionally, we have to try to manage the excess testosterone. Sometimes going on a birth control pill that has a progesterone that's sort of decreased androgen active, then you can put them on that, and that will also help to decrease their testosterone because it increases this protein that's made in the liver called the sex hormone binding globulin. And so that actually helps a lot of people with their acne. Otherwise, spironolactone or medications like that. Some people do laser and other therapies. So it really is a patient-dependent thing. If we're concerned about the fertility and the subfertility issues, and you can't regulate your cycle, then a lot of people get fertility augmentation with an ovulation induction agent or other means. And so these are kind of the things that are out there. So, don't fret, don't feel shame, don't be upset that this is something that you can't get under control, because hopefully we can. Realize that a lot of this, can be controlled, but, working with the right healthcare provider, hopefully we can get you to a point where we're treating the symptoms that need to be treated and helping you along the way. And so that's PCOS for brown girls in a nutshell. Again, I'll have another discussion about some of the treatments and data on that, but I just wanted to emphasize this because I see so much of it in my office, and we have to just, focus on issues that and how we can improve our quality of life, but also, how we can improve our overall health. And so that's one thing that I wanted to discuss today. So I'll see you guys next time. Please like and subscribe to my channel, and Gyno Girl out.